Okay, so without further ado, I'm so excited today to have Dr. Jacqueline Ann Santa Maria to speak to us. She's from the Valley Health Medical Group in Wayne, primary care physician, and she's going to be talking to us about osteoporosis. Thank you for joining us. Take it away.
Thank you, Susan. Good morning, everyone. As Susan mentioned, my name is Dr. Santa Maria. I'm a family medicine physician, actually fairly new to Valley Medical Group, not new into practice. I joined recently, and I was asked to talk about a chronic disease that causes, our bones to be weak and more prone to breakage, actually affecting 1 in 2 American women. This is according to our National Osteoporosis Foundation. Let's talk about our objectives. So down below, you'll see our objectives for today. We're going to try to define and talk about all about osteoporosis, identify your risk for osteoporosis, understand what lifestyle changes you can do to prevent osteoporosis, and know how much calcium you need on a daily basis for healthy bones, identify changes that you could also do to help fall preventions, to help you prevent you from having falls that could lead to fracture, especially if you have osteoporosis. So before we proceed, let's take a moment here to ask ourselves the following questions, okay? And as we go through our lecture, we can go back and try to associate these questions and how they are related to osteoporosis, see if, you've answered yes to these questions, and maybe you are affected, maybe, you need to learn more and be more proactive and ask your primary care doctors more about screening for osteoporosis and what you could do to prevent osteoporosis. So do you have like a small thin build? Did anyone in your immediate family ever break a bone as an adult? For women, have you gone through menopause? Also for women, did you go through menopause early? Did you have like a procedure wherein you had to have your uterus removed, or what we call hysterectomy? How is your diet? Is your diet low in dairy products, low in calcium? Are you physically inactive? Do you drink more than 1 alcoholic drink per day? Do you or have you smoked cigarettes? Have you been taking medicines with cortisone or steroids, or what we call sometimes patient knows this as prednisone for inflammation, arthritis, or certain conditions such as like asthma? Some patients with cancers take steroids as well, and if it has been more than a year, or have you been taking steroids or cortisones for a longer period of time? Do you take any thyroid medications, or do you have any thyroid conditions? So these are the questions that we can try to answer and how they correlate with osteoporosis. So what is osteoporosis? So oftentimes, actually, at least in my practice, when I say osteoporosis, patients often think of another bone condition called osteoarthritis, which is a little different. It was a lot different because osteoarthritis is primarily inflammation in the joints and primarily causes a bone pain. On the other hand, osteoporosis, when we say osteoporosis, it's actually a disease characterized by loss of bone mass over time that leads to weak and brittle bones. So think of it as being porous or being softer, but having a softer bone. So you'll see in our picture here on the top part, which is the blue circle, you'll see like a normal, like trabecular part of the bone. When you look underneath the microscope, or like you can see there's less spaces. The trabecular itself are like a lot thicker, okay, or increased in size. And comparing it to the bottom picture where there's a lot more spaces in between the trabeculum and basically causing us to have softer or weaker bones. this is another, visual picture to see what is the process or what's going on when we say osteoporosis. So towards on the left side of your screen, you'll see this is more of like a normal bone. So if you cut the bone in half, you take a look at the inside, you'll see there's less spaces. And then as we go along towards the right of the screen, you'll see the disease progression, wherein here the trabecula becomes more thinner, and then you'll have more spaces and bigger picture. Now, I don't always have the luxury to show this picture when I see patients in the office. So oftentimes I'll grab a sheet of paper, I'll draw them a picture, and the picture looks like this. As you can tell, I'm not that of a good of a big artist here, but it does the job. So it's still, it conveys the what I'm trying to tell the patients on why there's less mass, there's less meat. Sometimes I use that term in our bones, causing it to be more weak and more prone to breakage. So why are we talking about this? Why are we talking about osteoporosis? Why should we be concerned about it? So pulled up some numbers here. Everyone should be concerned for yourself, or because as I mentioned, bone development goes throughout our life, and osteoporosis as a disease, it actually affects all people of all races, ethnicities. It's some have an increased predilection to develop osteoporosis, though, but it does happen in all races, ethnicities, and in both sexes, not just in women. In the United States, an estimated about 10 million people aged 50 years and older have osteoporosis. Most of these people are women, but about 2 million are actually men. And just over 43 million, or closer to this number, 44 million more people, including of the like 16 million men, have low bone mass, so putting them at risk for osteoporosis. Um, some This is actually from the National Osteoporosis Foundation numbers that I've pulled up in my reading. So as we grow older, okay, the numbers to kind of like on an average to note of is by age 30. That's the age when you actually reach your peak of your bone development or bone mass. And then by the golden year, like when you reach the age 50, that's when we start to note the bone loss increases, especially in women. Now, this is also around the average the time when women develop like menopause, or what we call like a physiological change, wherein women stop getting their periods on a monthly basis, and it's usually driven by hormonal changes. So no periods for clinically no periods for 12 consecutive months. Another number that struck me here on why it's important to talk about osteoporosis is the $19 billion. So this is their estimated annual cost of osteoporosis-related fracture. So not only if we can prevent osteoporosis or delay a progression of osteoporosis, and probably lower the osteoporosis-related fractures, we can lower this medical cost, and maybe to direct that money that we can save towards other medical conditions. So let's backtrack and talk about our bones, okay? So though we don't see it with our naked eye, it's actually a living tissue, okay? The bones are continually remodeled throughout our life, okay? The bone, the body deposits new bones and then removes the old bone. So you see here, during our adolescence year, that's the greatest bone growth period. That's when we try to listen to our parents and our grandparents when they tell us to like drink your milk, drink your milk. That's when we achieve the greatest bone growth at least. Okay, and then by the time we enter our young adulthood, by age 30, I told you that's most the average time like where we peak, and the maximum. That's when the bones reach the maximum strength and density. And then in our middle adulthood, then that's when we gradually lose our bone masses, and then the remodeling process we're in, it's supposed to make new bones slows down. Okay, by the golden age of like 50 or over the age of 50, um, that's when we really have to really focus, you know, with our proper nutrition and exercise to strengthen our bones, because we don't, develop it as much anymore. And then by age 70, so sometimes most of us would have developed already osteoporosis, um, or at least at that age, when we have osteoporosis, or if we are unfortunate to have osteoporosis, we try to prevent falls. So our focus is preventing falls so that we don't break a bone or have fractures. So what causes osteoporosis? Osteoporosis, two main things with developing osteoporosis. If optimal bone mass was not achieved during our bone building years, so like as we were growing older, we didn't really have like too much, we didn't have enough like calcium or vitamin D, we didn't achieve like the optimal, or like deposit for calcium to build our bones. And then the main one is actually if bone loss occurs too quickly or bone replacement occurs too slowly. Now, this mechanism is actually what we're focused also with development of osteoporosis medications. So most of our medications are directed towards decreasing bone resorption. So we have like two cells here that are involved. We have their osteoclast. So they're in charge of like bone resorption. And then we have our osteoblast, which is the good ones that we want to have, because they help us like build new bones. So in this mechanism of action, we have medications that help with osteoblast, and then they help inhibit the osteoclast. So they almost always like work with this. Some medications also help us like absorb calcium and vitamin D. Okay, and so with increased in resorption and decreased in formation, we tend to have this, and this is the same picture that I've showed you guys earlier, when we have a decrease in trabecular number, decrease in trabecular thickness, and then increased in the trabecular spacing, which all leads to like increased in fracture risk. So speaking of risk, okay, so for osteoporosis, we've identified risk factors, and we've grouped them into two. So we have the uncontrollable risk factors and we have the controllable risk factors. So uncontrollable, we can't really do much, such as like age or aging. This is something that we can't do really much of. Or menopause. As I said, it's almost part of like a physiological change for women. With hormonal imbalance that occurs around the age of 50. Race, Caucasian and Asian race, Asian tend to have a likelihood to develop, Asian Americans are likely to develop osteoporosis compared to other races. And if you have a family history of osteoporosis, if you have a small or thin frame. And on the other hand, we do have risk factors for when we have more control of, okay? So if, for those who are smoking, stopping to smoke, those who have had low a dietary intake of calcium and vitamin D, so we can increase those. Those who have a lack of physical activity, we can increase their physical activity. Certain medications, so sometimes though we are put on medications that we have to take, but it's a good topic or a good discussion with your providers who's prescribing you the medications to discuss, is there something that we could do, take in as an alternative, or decrease the dose, or maybe take it in a shorter course or a shorter period of time. Excessive alcohol or caffeine intake as well is one of the risk factors that we can control. This is the same, is identifying risk factors for osteoporosis. We did mention that it does happen in both, John, when men and women, but more likely in women would get osteoporosis than men. And medication. So it's mentioned earlier, talking to your providers, because certain medications is associated with osteoporosis. So those who are in long-term use of corticosteroids, steroids, when used over a prolonged period of time, and for conditions such as like arthritis or asthma, lupus, Crohn's disease, chronic lung disease, and diseases of the kidneys and the liver, you want to talk to your provider. And if you can't get off of the steroids or the prednisone, maybe talk to them about if should you be screened earlier for osteoporosis, so that, because knowledge is key in preventing diseases and things like that. If you take antacids that contains aluminum, when used on a daily basis for a long period of time. So these are actually over-the-counter. Maalox is used for those who have hyperacidity. I usually talk about, like, with my patients, if you have to use it, it is there for you to use. It's there to alleviate your symptom. Maybe you can use it on an as-needed basis or the shortest course possible. Shortest course duration. And then certain seizure medications can also or is also associated with osteoporosis. So most of these, actually, the anti-seizure medication, they actually have a direct osteoblast. They inhibit, actually, directly the osteoblast, which I mentioned earlier, we used for bone growth, the cells that we use for bone growth. Okay. And then thyroid medication, so similar to the steroids, they reduce the body's ability to absorb calcium and increases how fast the bone is broken down. So when you're on thyroid medications, it's good to talk to your doctor. So, and if you're also taking calcium supplements, actually, is a good information to take it at least 6 hours apart, so it doesn't inhibit with the calcium. So you can still take it, that the spacing, you should just follow the spacing so that it doesn't interfere much with the calcium absorption. Medical conditions. So some medical conditions can also result in osteoporosis. So diabetes is there. Diabetes has a lot of complications, not just osteoporosis. We have from absorption, from the microvascular, macrovascular effects of diabetes. There's just so much complications that can happen with a diabetic person, especially if their blood sugar is uncontrolled. Hypogonadism, or loss of male sex hormones, primarily testosterone, because testosterone has a direct effect on the androgen receptor on the osteoblast. So again, the osteoblast is mentioned here, which helps us with our bone growth. So if you lack testosterone, then you have more of like what do you call this, a direct effect in it's supposed to like help with like bone growth, but if you don't have it, then it's basically not helping. And then hypothyroidism, or having a hyperactive thyroid gland, also is known to affect or accelerate bone remodeling. Congestive heart failure, from my readings, goes both ways. Patients who have congestive heart failure have increased risk of developing osteoporosis. It's also known that osteoporotic postmenopausal women have higher lipid levels or cholesterol levels, and actually are at increased risk for developing heart disease and stroke too. So it goes both ways for osteoporosis and congestive heart failure. Chronic kidney failure is there, anorexia. This is more of a nutritional deficiency, and also they have smaller build, and then gastrointestinal diseases as well, also for like malabsorption and things like that. Let's talk about symptoms. I mentioned osteoarthritis earlier, and most of the time when my patients complain that they have bone pain, joint pains, and things like that, they think it was the osteoporosis. It can cause pain, but not yet so much on the beginning stages. Most of the time, osteoporosis would not cause you pain. It's actually we can call it like a silent disease, because you might not have any symptoms, especially in the early age. When you do break a bone or have bone fracture, then that's when you're gonna have bone pain. Obviously, a fracture would hurt. There's another type of fracture that usually occurs with osteoporosis, and that's compression fracture. So some of us, like, may have had like an x-ray and they mentioned compression fracture. So compression fracture is a different type of fracture wherein the spine, they how like our spine or vertebra are stacked together, and because they're so brittle and weak, and over time it's added stress on that, and it's compressed. So this causes like an abnormal spine curvature, or what we call kyphosis, and now we start to see like hunching of our backs and things like that. So over time, because of the posture and things like that, this can also cause pain or back pain because of the collapsed vertebrae. So how do we diagnose? We can use either a DEXA scan or an ultrasound, but primarily the more common one is the DEXA scan, because it gives us like scores. There's two scores actually. When you have a DEXA scan, it's basically an X-ray. There's two scores that we use to identify osteoporosis. One is the T score, wherein we compare your bone mass to a young, adult, okay, female adult, or then the other one is a Z score, wherein we compare your bone mass to adults on the same age and the same gender as you. So who should get a bone density test? There's a lot of groups that would come up with a recommendation, but the mean or like the average recommendation, so let me just show you here screening recommendations. So like we see here, National Osteoporosis Foundation, they recommend bone density testing for women 65 years old and postmenopausal women 65 years old based on the risk factor profile. They also recommend bone density testing for all men 70 years old and men aged 60 to 69 years old based on their risk factor profile. The US PSTF, or United States Preventive Services Task Force, most primary care physicians follow these recommendations. So we screen women aged 65 years and older, and in younger women whose fracture risk is equal to or greater than that of a 65-year-old. So we still identify the risk factors that you have. For American Congress of Obstetrics and Gynecologists, they do recommend bone density testing for women, all women 65 years old, and postmenopausal women 65 years or younger than 65 who have one risk factor. And then we have the American College of Physician Clinicians. They do recommend the above also, but they also added in that older men to screen older men for osteoporosis, and they also mentioned those who are at increased risk for candidates for drug therapy should be treated for osteoporosis. So, in summary, all women 65 and over and men 70 and older, I recommend that you get your bone density test to screen for osteoporosis. All postmenopausal women and men ages 50 to 69 with additional risk factor. And then adults with a fracture after age 50. Women who have been on hormone replacement therapy for prolonged period of time. So I mentioned that earlier. So sometimes we can't avoid, and you really need to be on medications, or some of them are have been on hormone replacement therapy or steroid use for a prolonged period of time. So you should talk to your doctor about getting a bone density test if qualified, or depending on your risk. Anyone currently being treated for osteoporosis to monitor disease progression, adults with medical, lifestyle, or medication-related risk factors associated with osteoporosis. So in primary care, prevention is key, okay? There's different types of prevention. So we have our primary prevention, so, and then secondary, and then tertiary prevention. So primary prevention, an example would this be is detecting a disease when it hasn't happened yet, or trying to stop the disease from happening. So one good example would be, giving vaccines or providing vaccines, so for you to, prevent a certain disease. Okay. And then the secondary prevention is actually you have the disease and we're trying to catch it, or we're trying to detect it at the early phases of the disease. So early detection. I would put like screening for osteoporosis for that. Let's say if you already have osteoporosis and we're trying to catch it early on. And so similar to when you get your colonoscopy to try to screen or detect colon cancer at early stages, or getting your mammogram to try to detect breast cancer at an early stage. Tertiary prevention is you already have the disease, it's already established. Let's say you already have diabetes. Now, what can we do or prevent complications? So let's say, for example, if you have diabetes already, what can we do to prevent diabetes complication or to slow the disease progression as well? So for osteoporosis, we mentioned earlier, one of the risk factors is having low calcium and vitamin D in your diet, because we know the importance of calcium in bone development and bone growth as well. So calcium, as I mentioned, it's essential for bone formation and maintenance of a healthy bone. The recommended calcium intake is between 1200 to 1500, or sometimes you'll see some readings it says 1300 milligrams in adults 50 years old and older, and in post menopausal women as well. So I put a picture in here just to give. There's more food than these in the picture. To just an example where you can get your calcium from your dietary intake. So you have obviously your milk, your cheeses, almonds, sardines is also a good source of calcium, broccoli, and spinach as well, your green leafy foods. It's important that we learn how to read labels as well, for to determine, are we getting, how much calcium are we getting. And if you see here, so this is an example, we'll try to like explain and read this. Okay, so I think the first thing we have to know is the DV. So DV stands for daily value. So you this is calculated based actually on a 2000 caloric diet. Okay, and if we are going to stick with the recommended of 1300, so we need about 130% of calcium on the daily value of calcium. So it to make things easier. So if you see like it says here, like on this label, calcium of 30%. Okay. So looking at the serving size, if you had 1 cup, that means you're getting 30% of calcium in that serving. And then you add a zero, then that's the amount of calcium in milligrams that you're getting, and you're trying to get 1300 milligrams per day. So you add in all the nutrition facts. Look into the nutrition facts, and then you can see how much calcium that certain food is giving you. Okay, so if you had 2 servings of this, then you'll have like 60% of calcium, and you're up to like 600 milligrams. Vitamin D is equally important because it helps us absorb calcium. And the vitamin D is actually in units. So the way we measure it is in international units. And the recommended for vitamin D is 400 to 800 units for adults younger than 50 years old. And then for those who are over 50 years old, we recommend to have at least 800 to 1,000 units of vitamin D. And these are the examples of food where you can get vitamin D from. Smoking and osteoporosis. So I think at this day and age, we already know like a lot of like bad effects that smoking can do to your body. So smokers, this is just in the summary, but there's a lot more that smoking can do harm to our body. So smokers don't absorb dietary or supplemental calcium as efficiently as non-smokers. Okay, women who smoke have a lower levels of estrogen compared to non-smokers and frequently go through menopause earlier. And here's other, like specific examples on how smoking can affect our bones. So it actually impedes this hormone calcitonin, which also is helpful for building our bones. Okay, it increases the hormone cortisol. So cortisol is known as like our stress hormone, leading to bone breakdown. It damages our blood vessels. Okay, so it interrupting the supply of blood to the bones, causing fractures. And nicotine, which is in the cigarettes, and free radicals actually kills our osteoblast. And as you remember, we need our osteoblasts for our bone growth. Exercise. So exercise. So it is recommended to do 30 minutes of moderate physical activity in most days of the week, preferably all. Actually, the American Heart Association and American College of Cardiology do recommend 30 minutes of moderate cardiovascular exercise also. At least 5 times a week, or what we call a minimum of like 150 minutes per week to prevent heart disease. So this is also going to be good for us to prevent osteoporosis. So we talk about weight-bearing exercises such as walking, stair climbing, hiking, weightlifting, and other team sports. For balance training such as Tai Chi, this was interesting when I read about this. So they've done a lot of studies with Tai Chi, and it is known that is very helpful in preventing falls. When they did this study correlating it with osteoporosis, it didn't really have that significant effect as it did in preventing falls, in correlating it with development of osteoporosis. But because it's good for preventing falls, it helps us with the balance, and it prevents us with falls. So indirectly, it's definitely also helpful for those who have osteoporosis, because if you have osteoporosis, you do want to prevent your falls. And that's our next slide, actually. So fall prevention, you want to inspect your home, make sure there's no much clutters that you can trip on. So you want to get your eyes checked, your ears checked. Okay, so if you can't see well, you tend to stumble. Ears checked too, because you know it, that's very close. The inner ear is actually very close to it helps us, our cranial nerve to help us with our balance as well. um, Check your blood pressure. So if you're having low blood pressure or high blood pressure, you tend to have symptoms that makes you unsteady. If you can have like dizziness, that makes you unsteady and put you at risk for falls. Review your medications. A lot of times we're taking medication that can make us feel drowsy, unsteady, and increases our risk for falls. Or sometimes like medications that can increase confusion and things like that, can also increase our risk for falls. Um, Avoid lifting heavy objects, wearing low-heeled shoes, having a personal fall prevention assessment. And this is a good plug because um, the Valley Hospital Outpatient Rehabilitation Centers offers this. Actually, they could do a personal fall prevention assessment for our patients, and they offer physical therapy. They offer occupational therapy. They have nursing. If you need referrals to appropriate specialists, they can be helpful. Most of the specialists that I work with as a primary care providers would be like the endocrinologist and the rheumatologist. So sometimes they help me manage osteoporosis with medications, and also managing or monitoring disease progression. Just we were just going to touch on this a little bit. I feel like this is medications are supposed to individualize like discussed with your primary care doctor or your endocrinologist or rheumatologist, because it's not like a one size fits all. But if you recall earlier, with the mechanism of action, with trying to decrease the bone reception and increase bone growth, most of these medications are directed towards that. Okay, alendronate, it's more commonly known as Fosamax. Okay, so it's one of our common medications for osteoporosis. Risodronate is also one. Another common one that we see that it's by injection is um, denosumab, which is Prolia. So these are all it should be prescribed for women with osteoporosis to reduce the risk of hip and vertebral fractures. Pharmacologic treatments are also recommended to continue for 5 years. During this time, bone density monitoring should not really be done, but after that, you should really monitor it. And then just another interesting that I see with my reading. So there is a change. This is like an evolving topic. The use of menopausal estrogen therapy and menopausal estrogen plus progesterone. Um, in 2008, we were using this, and this was one of the main treatments for osteoporosis. But they've changed the recommendation to should not be used at least as first line for women with osteoporosis. And I think this is from the recommendation of the American College of Physicians, as they reviewed. Um, there was a study that they did in 2017 with a women's health initiative, and because every time you prescribe a medication, you always try to weigh the risk and the benefits. You always want to try to weigh the adverse effects that you could have, and because of the adverse effects that are linked to estrogen and progesterone, or taking of estrogen therapy or hormonal therapy, this had set back, as they're no longer used as a first line, or at least for treatment for osteoporosis. The decision to treat women 65 years and older who have osteopenia and are at high risk for fracture should be based on a discussion of patient preferences. So that, as I said, it should be an open discussion between you and your provider, taking in consideration your fracture risk profile, the benefits and harms of the treatments, the cost of the medication. These are all the things that we take in consideration. And lastly, treatment with biphosphonate should be offered to men who have osteoporosis to reduce the risk of vertebral fracture. It's another picture for common treatments for osteoporosis. So we mentioned about the Fosamax or alendronate. They're considered as an anti-resorptive medications. Some anabolic agents are there as well. Um, they're a little bit more on the aggressive side, because they activate cells responsible for new bone growth. So it helps us. This is more used in more severe cases of bone loss when we're trying to build more. The common medication for this one, or that I see out in the market, is Forteo. And weight bearing moves. So this isn't the type of exercise that requires. So I didn't mention this. I was going to mention this when we were talking about exercise earlier. I probably should have mentioned also, like, exercises that we should avoid when you do have osteoporosis. So like exercises that involves like rounding or curving your spines, you want to try to avoid that. Exercises that would twist your spine so much, you should probably avoid that when you have osteoporosis. And deep hip stretches, such as like the pigeon poses, which we probably should avoid that if you have osteoporosis. That's when you like have your arms stretched, and then you try to like raise your upper body with the use of your hips. So those probably would you want to try to avoid hurting your spine. Okay, so as we end, okay, so as we go towards the end, so the action sets up today. Hopefully, you're going to check if you're getting enough calcium. Okay. You're going to check if you're at risk for osteoporosis. Also good to check your environment. Okay. To reduce the risk of falls. Okay. Consult your physician, talk to your primary care doctor, and discuss about your risk, or discuss about screening for osteoporosis. And that's about it. Thank you
Oh,
for listening.
thank you so much. How wonderful. Really appreciate it. So much information. Um, I'm going to ask, we have a lot of questions. I'm going to, if you have some time, can answer some of them. And I'm going to try to, let's see, one of the questions, and forgive us if you've mentioned this in your lecture, you were so thorough, but a question's about Prolia or
Mhm.
Zometa. Okay. Is Prolia or Zometa more effective on building and maintaining bone while a patient is also on an aromatase, or I'm sorry, AROMATASE inhibitor? Do you know what that is? So
Yes, yes.
do either have more side effects being on that inhibitor is the first question.
So if you're on aromatase, is that the question? If you're
Yes,
on aromatase,
sorry.
are they asking for like the drug to drug interaction with using Prolia?
Which one is more effective, Prolia versus Zometa, and which has more side effects is the question. While also on the aromatase inhibitor.
Yeah, I mean, I I I've used Prolia more than Zometa, so I've had like more readings on the Prolia, but a head-to-head comparison between Prolia and Zometa, I haven't gone into reading about that yet, or found any studies that compares it like on a head-to-head basis, for that matter. Um, and then Prolia, interacting, you said like with drug to drug interaction, is that correct?
Yeah,
With
the aromatase inhibitor. Yeah.
aromatase inhibitor. Okay. So, and I'm just trying to get like what the background here is. The patient probably was a cancer patient, right?
Yeah, we're limited and we can't get too
Yeah.
specific. I want to make this announcement to everybody too. Just like in our live programs, it's very
Mm-hmm.
hard when people get too specific because we have so many questions, so but
Yeah.
I don't, yeah, I guess that's what the aromatase
Yeah.
inhibitor is used for.
Because that is one of the indication for Prolia, is to treat is a treatment to increase bone mass in women at the high risk for fracture when receiving adjuvant aromatase inhibitor therapy for breast cancer.
Okay.
So yeah, so that's a little bit more specific when it comes case to case history of the patient.
Right. Can you answer a question about if a patient gets a large bone fracture while on, for instance, Prolia, Zometa, or Reclass? How much does this complicate treatment and bone healing if somebody has a large bone fracture while on these medications?
So if they're already on Prolia and then they develop like fracture, okay. So so there is a side effect. Oh, so what is the cause of the fracture? Was it because of like a fall or an injury, or was because there is also like possible like side effects of for these medications that cause like avascular necrosis and actually fracture also of the hip. So I know it's unusual to hear of like that, but some medications have adverse effect that causes you to also have another type of like fracture as well. So if if it's not as an adverse effect, then we still continue the Prolia as a treatment for the osteoporosis. We don't stop it. But if it is found to be an adverse effect, then we probably would likely have removed the patient from taking the Prolia.
Additionally, what are the general, because we're getting a lot of specific medication questions here, but what in general do you find, or in your practice, side effects of some of the medications. Is that something you can speak to,
Oh,
or?
yes, yeah.
Mhm,
So in general, so biphosphonates and even Prolia, which is denosumab, can have, and this is probably not something that you don't want to hear. I mean, something that you don't want to hear around this time or around our flu season. You can have actually develop like flu-like symptoms, fever.
mhm,
You can also have bone pain, joint pain, changes in your bowel movements is also known, tiredness, low energy levels. As I said, feeling sick. So you want to get your kidneys checked. In fact, before receiving Prolia, now it's required to check your kidney function as well.
mhm.
Um, Before injecting Prolia and knowing your calcium level, because it can also affect that or decrease the calcium levels in your blood. So that's like the more in general like side effects of biphosphonates and denosumab.
More in general, right?
Mhm.
Do you hear anything? Do you ever recommend creams? Is that something, the effect of creams for osteoporosis? Is that
Not as a current recommendation.
okay?
I are are they thinking about when they have pain? I think
I
that
guess so,
probably
sure.
is right.
Mhm,
Yeah, so more of like bone pain
mhm.
and things like, because there are topical anti-inflammatories that are given for osteoarthritis, so that's the one that has more of common like the bone pain. So remember, with osteoporosis you don't necessarily have pain initially, unless you have fracture or compression fraction, then you can develop like the pain after.
Okay. And do you, by any chance, do you know if like somebody is, if there's a pending major dental treatment, you know,
Yeah, that's a
you,
good question.
yeah, are you,
Yeah.
how long should you allow healing before starting maybe Prolia or medication? What would you?
Yeah.
Mhm,
So that is a good question. So osteonecrosis, specifically of the jaw, okay, is another major like adverse effect that could happen, right? So we're very cautious. So it, I've talked about this with the endocrinologist, right? So before they start the medication, they always ask the patient, do you have any impending like are you planning to do dental work like in the near future, okay, or like next week or like next month and things like that? Because if you do,
mhm,
we would probably end up like delaying the start of your treatment
mhm.
until you get this, because osteonecrosis usually happens like you say you have like dental work um, and it affects because that's one of the side effect of the drug, so we don't want to complicate the healing when you have dental work,
Mhm.
and the worst, if you develop osteonecrosis. So, and then some, and I've seen some endocrinologists do this, that if they are having, depending also on the dental procedure, actually, on how teacher said, if it's just like cleaning or simple feeling, I don't think they're gonna stop it. But if it's like, let's say it would involve maxillofacial surgery, and it's involving really close to the jaw, then they'd probably hold the medication for a month or two before going in with a procedure.
Okay.
Yeah.
Thank you. Are there, would you suggest, or do you know of any medications that help build osteoblasts to your knowledge?
Well, that's the goal for the biphosphonates. It's like to boost the
Mhm.
osteoblast in bone remodeling, or creating new bones, or building new bones for your body. That's their goal. That's and it, it, actually no, I'm sorry. Let me backtrack. That's the goal for the anabolic one. So the anabolic medication, the Forteo, if
Mhm.
brand specific, that's the goal for that, is to increase the osteoblast and increase bone growth. So but there's also like a lot of like side effects with the Forteo, so they really want to just sort of reserve this for those who have severe osteoporosis.
Okay, great.
It could, yeah, because yes, especially we use it in caution if you have like elevated calcium levels. We
Mhm.
don't want to, like, take it, if you have increased calcium levels, because it can tend to do that. So always remember, like with calcium and or like any vitamin and mineral deficiency is something that we treat also, but we also don't want to get the opposite, which is like hypervitaminosis or like increased vitamin D, like too much or vitamin D toxicity, which could also have symptoms you can also develop from having too much vitamin D.
Right.
So like, and women, we should not use like um, Forteo also for those who are pregnant, nursing, if you've been diagnosed with bone cancer. So certain bone cancers have increased calcium levels also to begin with anyway. So you don't want to use Forteo as well.
Okay. Yeah, a lot of questions about more holistic vitamins, supplements, almond milk, if
Yeah,
that
no, no.
helps. Yeah.
I mean that, and that, I'm all for that too. Like,
Mhm.
it's good if you can just get your dietary, your calcium, and your vitamin D, through your dietary supplements and dietary, like your daily food intake. That's why it's good to learn how to like read labels and things like that. Um, it's a good approach as well.
Right, to do as much as you can naturally,
Mhm.
sure. Um, we just had a lecture on spinal stenosis, and so there's a lot of, questions about like having other
Mhm.
spinal issues
Yeah.
like lumbar stenosis,
Hmm.
cervical issues.
Hmm.
So do you have any kind of advice or suggestions as to how I can safely exercise without further affecting the stenosis in both areas? That's a great question.
Yes, yeah, and then and so I started exercising myself, myself actually, and I think the common things that I hear from the instruction, the exercise instruction, is you listen to your body, right?
Hmm.
So when a certain exercise starts to hurt, then you step back. Okay, so
Right.
similar to when you injured yourself, we hardly ever say stop exercising. We
Mhm.
always say do your exercise, do what you can, and if you start to have pain, you listen to your body, don't push it, maybe
Mhm.
step back a little bit and then gradually slow return to what you could do. I
Right.
did read something about, like when I was reading about compression fracture, that it doesn't usually affect the nerves. Okay, so I know we're talking about the vertebral body being compressed, and how like patients already having like a hunchback and things like that. So posture alone, the muscles, they're gonna hurt, but less likely, I think, affecting the nurse, at least from what I've read.
Okay, great. Um, Also, there was a slide on a study outlining the harmful impact of estrogen or osteoporosis. I don't know if you can find that. Someone was
Yes, yes,
asking
yeah.
to,
So this is also, Susan, you sent
Mhm.
me an older slide, and
Right.
this wasn't there because I believe that slide was like from 2008, and that's the
Mhm.
let's see here. Let me see if, oh, did I go past it?
I thought I saw it, yeah. So it's an older study.
Yeah, so the newer study, they're no longer recommend in the past. So here, okay, so in the past, okay, menopausal hormone therapy with estrogen and progesterone was used to prevent osteoporosis and coronary heart disease. Okay,
Mhm.
now in the new data with Women's Health Initiative done in 2017, because of the there's, you always want to weigh the benefits and the harm, right? The risk and the benefits, and because of increased risk for adverse outcomes such as deep venous thrombosis, thromboembolism, or blood clots, and then breast cancer as well, correlating with estrogen. um, in light with that new data, okay, um, they no longer, so the recommendation from that data is the menopausal hormone therapy, estrogen therapy for menopause, are no longer used for prevention for osteoporosis and other certain, that's actually chronic diseases like chronic heart disease. It was actually also used before for chronic heart disease prevention.
Okay.
So yeah, so that's definitely something recent also that has occurred in just in the last few years.
Okay.
I mean, people. I want to clarify. So patients who are already on it for estrogen therapy, I don't want you to to get excessively like alarmed as well. Like I'm sure the risk of being on hormonal therapy was discussed with you before you started. They don't recommend stopping it. Okay, so like say you're already on hormonal therapy and it's just that it's not no longer recommended as a first line for treatment for osteoporosis and also as for prevention.
Okay. Yeah. It's hard because so many of these questions and these discussions need so much to be had by your
Yeah,
primary
actually, that's why.
physician, and I know that's what you are, but a lot of times what we'll hear from people is we don't have that time to speak to someone. For the people asking about the cancer meds, that's important to talk to your oncologist. It's
Yeah.
hard. I know it's not.
So
And
so that's why in the beginning of our learning objectives, it's not we didn't actually even include like the treatment because it's really an individual discussion with your provider. With going on these medications. I don't, like you want to make sure your kidney function is good. You want to, I just want to give you like ideas on like what to talk to your providers. Like, you want to make sure your kidney function is good, your calcium level is good, your vitamin D level is good before you go into this medication. Are you on medications that are actually inhibiting you to absorb calcium or lowers your calcium level? So some of us have thyroid conditions, so some of us have like diabetes and things like that, so it increases your
right.
risk. So it might be a different approach for agents for with regards to like treatment.
Just even medications, people have questions about staying on Reclass, staying on Prolia. Like,
Yeah.
to your knowledge, are there any studies of how long that they should be taken? Or, that's another
The one
concern.
that I found, and I think I did put that in the slide, was the recommendation was to stay on these medication for 5 years.
Mm-hmm.
But to be honest with you, I've seen endocrinologists like place the patient longer than that, and I've seen some who are taking it shorter than that. Okay, also, so like let's say if they're having more side effects, see it says here pharmacologist should. This is a recommendation by the National Osteoporosis Foundation that I placed in your pharmacologic treatment should continue for 5 years, during which time bone density monitoring should not be done. But at the same, it depends. What if like I monitored your DEXA scan? Let's say I talked to a patient. Okay, let's monitor where you're at right now, and then if you want to try to come off, let's try, and then let's redo your DEXA scan instead of like 2 years in 1 year time, and I see that there's a significant decrease. I might decide to put this patient on the you know the medication for osteoporosis again, if there was a significant decrease, or maybe try a different one, maybe switching from Fosamax to Prolia and things like that. So it really depends. So but this is the recommendation that I found, was to at least continue for 5 years. Most providers would stop after 5 years, or 4 years and things like. So it really depends.
Right. Yeah. Somebody else was asking about relaxafine, and again, 5 years. Somebody said they're on it 5 years. You need to talk to your doctor. So,
Yeah.
sure. And I'm sorry if you mentioned this. Are you familiar with OsteoStrong fitness type machines? Those type of machines at all, or
OsteoStrong. Well, no, actually, no, I haven't
no?
heard about that.
Yeah,
No.
I know that's something. All right. So somebody had asked about at Valley. We are providing, and it's a very new program. Um, it's a bone health exercise center at Valley. We're just starting a program. They're actually right now. It's wonderful. It is a course that's being given once a week. It's an hour. It talks a lot about certain exercises to help with these issues. Right now, they're in session. They will not be starting up again until May, unfortunately. The number to call, and I'm going to put this in a chat too. Okay, so for these bone health exercises, everyone get ready, get a pen. Here's your warning. 201 291 6090. That's 201 291 6090. And you call Kathy Newberg, Newberg, Kathy Newberg, Valley's Community Health Department. Again, it's no courses until May, but we're hoping to add more courses, as after May, we'll do that too. So, and I'm just looking, I think, a lot of questions have been answered already, people.
So that's the bone exercises program. That's like in general, like for everyone, but they could all actually also, have a physical and occupational like therapist do a personal evaluation and then do a customized program for them too, which I think
Right.
I believe I haven't gone to the outpatient rehabilitation center yet for Valley Hospital, but I think that they do offer like physical and occupational therapy as well.
We offer that too. Again, that's something to be discussed with, it's an individual case, and just one more question. In general, I think I know the answer, but is osteoporosis reversible, or can medication really only slow the process?
No, it's not gonna reverse like your normal like bone when you were like 18 or 20 or 30. But we do see some effects that wherein there is definitely improvement in the bone density.
That's wonderful.
Yeah,
I hear that too.
I've seen it actually with my my own patients where there is an improvement in their bone density scores when they go on the medication, so that it's promising.
And exercising, medication, doing some of these vitamins, and there are some hopeful situations.
No, there is. Yeah, there's
very much so.
Medicare patients actually, so I believe it's covered like at age 65, and it's covered every 2 years. And sometimes when I monitor in 2 years mark, and they've done all this like lifestyle changes, I do see like an improvement in their bone density score.
Wonderful. That is great. Thank you so much.